All right, let's get started again. I think we will now power through. So we're almost there. Thank you for sticking here for this long, dealing with me, listening to me for so long. I admire you that you're not tired of me. This is a very brief slide deck. I just would like you to know that a cost-effectiveness analysis is not the only type of economic evaluation that we can do and apply in healthcare. We talk mainly about cost-effectiveness and cost-utility analysis in this course. Cost-effectiveness, to be technically correct, cost-effectiveness is a type of analysis where we compare two or more alternatives, and we compare their costs and their effectiveness on health measured in some natural units. If the effects on health are measured in qualities or dollars, we're talking about cost-utility analysis. But you will likely see in the literature that cost-effectiveness, the term cost-effectiveness is used for both of these. However, we can even do just a cost minimization analysis. That would be pretty much the same thing. We just wouldn't measure effectiveness. We would just focus on the cost dimension. The benefit of this is we can just compare dollars to dollars, and we find whichever intervention is cheaper. That's it. We don't have to worry about some willingness to pay thresholds to figure out if the intervention is a good decision, or we just will compare the dollars. Comparative effectiveness is something similar, but we just focus on the effectiveness. We just compare two interventions, and we compare which one is more effective than the other one. Again, we don't have to worry about any threshold. We can measure the outcome in whatever units we want, because we're comparing just one dimension. And then, like, if one intervention leads to fewer flu cases, then that's it.
How come economics come into play? I mean, it's just like let's say a trial where we are comparing the effectiveness of two regimes.
That is true. Are you saying that given that we are not considering money, why is it economic, right? That's a fair point. This is just like how people talk about this. The thing is, one thing that maybe I would add is that economics doesn't necessarily need to involve money. There are camps. One camp would argue that it always has to. The field of economics is about distribution of resources, which can be measured in money. But there is, especially lately, the field of economics is evolving towards studying human behavior, how people respond to incentives, how they change their behavior, which may or may not include money. So it's not, economics doesn't have to be always about money. That's just like a quick side note. Anyway, very quickly, like, all these analyses may make sense at some point. Cost-benefit analysis would be, again, this same kind of analysis, but we would measure gains in health in monetary units. That is tricky. You can technically think of the willingness to pay threshold as a way to convert qualis into actual dollars. And then you would just compare whichever alternative has whichever alternative has the positive net dollar or rupee amount. All these types of analyses have the concept is pretty much the same. But what I would like to stress out is, let's forget actually about this example. Well, let's keep the cost effectiveness threshold at 400,000 rupees per quali gain. And let's take a look at our vaccination and no vaccination exercise. In this case, we found that the incremental cost effectiveness ratio is 25,000 rupees. That's substantially less than the willingness to pay threshold, than 400,000. So we would deem this intervention a pretty good deal. But the thing is, to make this intervention work, we need to vaccinate all elderly. It wouldn't work if we just gave it to 2 people. We need to vaccinate everyone, or at least like a good enough number of people to get to herd immunity, right? And so if we do the math, this is when the total costs come. Again, I don't know why the commas are this way, but this is like 1,586,000,000 rupees. That's what it would cost, assuming that in our population we have, I think we assumed 1 million people. So this is what it would actually cost. Do we have that money in our budget? If we have only, like 500 million, it's great that this intervention is cost effective, but we still cannot afford it. So keep that in mind, that the incremental cost effectiveness ratio is something like density of a material. But it doesn't tell you anything about if you can actually lift it or if it can fit in your pocket or something like that. So this is when budget impact analysis comes in. It's really like, it's a very simple, the idea behind this is very simple. Like, you only will look, do we have enough money in our budget to actually afford this intervention? It would be sort of a natural next step after a cost effectiveness analysis. After we establish that this intervention is a good deal, it still doesn't mean that we can actually do it. So budget impact analysis, after the cost effectiveness is already established, budget impact analysis focuses only on the dollar amount or rupee amount, the financial amount. And it's an analysis specific to the opportunity cost, and also like to the limits of budget of the pair. Usually for budget impact analysis, we consider only costs in the short term, up to about 3 years, because whatever happens next, that's future generations' problems. For this type of analysis, the perspective is the budget holder, whoever is going to pay for the vaccination in this case. And maybe I'll just keep going. This table shows a quick comparison of budget impact analysis and cost effectiveness. What are the main differences? So in the study perspective, for budget impact analysis is the one who pays, the budget holder. In cost effectiveness, it depends. It can be the societal perspective, healthcare sector, and so on, patient. In budget impact analysis, we consider the current treatment mix as the alternative. So essentially we compare like all the procedures that we consider all the procedures that we would have to pay for using the budget. And if there's still some money left to do the new intervention, or maybe we can, get rid of some of the current procedures if they're not such a good deal, and we can maybe buy the vaccines instead. If we decide that we would shut down, some other screening program, we would save some money, but we could use the money to buy the vaccines. Time horizon in budget impact, as I said, is short, while in cost effectiveness analysis, it depends. It can be short, medium, or long. Discounting is important for future costs, especially if they happen in long or far future. So that applies only to cost effectiveness if our time horizon is long enough. Given that in the budget impact analysis the time horizon is fairly short, we don't have to worry about it that much. Sure, maybe like you can discount the second and third year, but prices will not change by that much within this short period. For costs, for budget impact analysis, we consider only the direct costs to the payer, while in cost effectiveness can be direct and indirect. For effectiveness, we talked about qualis and all these natural units in cost effectiveness analysis, while in budget impact, you consider only cost savings. Maybe if the intervention is maybe going to cost some money, but also save some money elsewhere for the same budget holder, that should be accounted for. And the results for cost effectiveness, we present them in terms of the ICER, the incremental cost effectiveness ratio, while in budget impact, it's just incremental costs. For sensitivity analysis, we just talked about all that. In cost effectiveness, for budget impact, it would be what would be most interesting are the extremes. What is the worst case scenario that can happen to our budget? I think that's all. I just wanted to tell you about this, and especially stress out that a cost-effective intervention doesn't necessarily mean an affordable intervention. Those are two separate questions. Questions?